good morning to all my respected faculty, my seniors, and my beloved juniors. I want to start my presentation with a case relative. Dr. Karthik, you are in screening C. Then a 65-year-old male with a non-case of hypertensive, diabetic, with he has a history of central chest pain and shortness of breath since 5 hours, was present to ED in honors system in front of screening C. And you received it on a research lab in Karigar state. And what will you do next? Yeah. What are the components of high quality CPR? It's with fast. Yeah. The rate will be 100 to 120 per minute. Which it is 5 to 6 centimeters. Should be minimum 5 centimeter. This is not a component of high quality CPR. And there should be effective chest recoil. That will happen. Then for the components of high quality CPR, we have to give the chest component hard and fast. The rate should be 100 to 120 minute rate per minute with a depth of 5 to 6 centimeter. It should be minimum 5 centimeter and with complete chest recoil. Because during the chest recoil, mostly the heart will fail. So this is much more important. Then there should be we should avoid hyperventilation. Why we should avoid hyperventilation? President sir, can you tell? Uh, by hyperinflation, it will increase the intrathoracic pressure, so that will decrease the venous return, it will decrease the cardiac output. So there will be very less likely of getting the ROS. And another point, it will be increase the gastric insufflation, so there is a chance of aspiration. And the another point is by giving hyperventilation, there will be hypocapnia. And hypocapnia, it will cause cerebral vasoconstriction. So there will be decreased cerebral perfusion. So for this reason, we have to avoid hyperventilation. Then there should be minimal interruption in chest compression. It should be less than 10 seconds. And we have to extend the CPR in maximum 2 minutes. They have to extend. These are the component of high quality CPR. So Dr. Karthik, you have given the high quality CPR for that patient. And then what are the things that you have to monitor? You have to attach the monitor. And the monitor is so pulseless VT. What you have to do? Yeah. The most important component of ACLS cardiac arrest algorithm are the high quality CPR and early defibrillation. So you have give early defibrillation of TCs of 200 joule. Then the CPR you have to continue the chest compression for 2 minutes. Then you have to assess the rhythm. And the CPR was continued for 10 minutes and the ROS being achieved. Because of the base component of high quality CPR and early defibrillation, we achieve the ROS. After achieving ROS, we feel like this. We can survive any patient, we can do anything, we can do any wonders. Then after that, we haven't noticed what are the post-ROS vitals. During that time, the OT technician, he has come, he has attached the patient has been intubated, and he has attached the patient to a ventilator with his known setting. We have known that the post-ROS vitals are there with patient has got intubated. With the breathing, he is on mechanical ventilation on BCP mode with a respiratory rate of 12 per minute with a tidal volume of 420 ml per minute with a equator of 100% and PEEP of 5 centimeter of water with a SPO of 100%. On auscultation, there is bilateral equal air intake with no added sound. On the circulation part, the blood pressure was 80 by 50 millimeter of mercury with a pulse rate of 60 per minute. Then we asked for a toilet stay subsequently. Then on the disability part, the GCS was U1 VTM1 and the RBC was 98 milligram per deciliter. And in the exposure part, the hypothermia was prevented. During this time, the ECG has been done and the ECG saw ST elevation in 2-3 area in the time. So how to manage the case? After achieving ROS, the HA recommends a post-arrest care guideline for management of person who is present with ROS. So my today topic is post-arrest care and its ethical issue in resuscitation. My name Dr. Golak Sir Patra and my moderator Dr. Akshay Sir. In my topic, I will be cover the following heading: why it is important, why do we have to give a proper post arrest care, and what is the post cardiac arrest syndrome. And I will be covering the post arrest care under the following guidelines, under the HA guidelines, under the ELCO guidelines, and what are the recent evidences, and what should we can do in our ED, and what are the ethical issues of resuscitation. So why to study? Why post carrier is so important? Because in the new AHA 2020 guidelines, in the chain of survival, you can find post care arrest care is a component. Because without if only we achieve the loss, this is not the end. Because the last chain, this is recently it is the recovery. So our last goal is to get a good recovery and to get a good favorable neurological outcome. Without giving the proper post cardiac arrest care, we can't be able to achieve that. So it is very much important to have to optimize the post cardiac arrest care because it is a part of our in the chain of chain of survival, and you have to follow strictly. The chain of survival has been organized in an integrated set of time to in a sensitive coordinated action to optimize the maximum survival. So it has to be followed properly. Now, what do you mean by post-cardiac arrest syndrome? This is mostly a complex pathophysiological pathway in which, when the body ischemia occurs following cardiac arrest, and there is when there is cross causative, there is a subsequent reperfusion that causes a complex sepsis-like syndrome that is called post-cardiac arrest syndrome. It starts the time when you got achieved the ROS. Regarding the pathophysiology of post-cardiac arrest syndrome, there are two components. There is ischemia, and when there is ROS, there is reperfusion. Due to these two pathways, initially in the cellular level, there is mitochondrial dysfunction. Due to the mitochondrial dysfunction, there is increased activation of apoptosis pathway, and due to increased release of cytochrome C. Also, there is more chance of cellular damage. Then both ischemia and reperfusion that leads to increased activation of reactive oxygen phase and increased formation with increased activation of inflammatory cascades. There is to increased formation of interleukin 6 and tumor necrosis factor. All these things during this ischemia reperfusion syndrome, the cells which are most vulnerable for our body is brain cell and vascular endothelium. So during all this process, this vascular endothelial cell and the brain cell are mostly affected. Due to the increased cellular apoptosis, due to the increased cellular death, there will be more endothelial damage and there will be more injury to the brain cell with cerebral edema in the pathology of post-cardiac syndrome. And due to the inflammatory process, due to increased cytokine storm, there will be sepsis-like syndrome, which is very difficult to manage. Then what are the components of post-cardiac arrest syndrome? There are four components. Due to the ischemia, the sites which are most vulnerable are the brain cells and the cardiac cells. So there are four components. One is post-cardiac arrest brain injury, which is the most common, with post-cardiac arrest myocardial dysfunction and the systemic ischemia reperfusion response that I have told, and the persistent precipitating pathology. Any patient who has got rust, we have to first find out the reversal cause, what is the precipitating cause that has caused the patient to arrest. Because if initially we weren't able to find this pathology, the patient will again go into the cardiac arrest again and again. It will be very difficult to manage. And this pathway will also different in different phases. The immediate phase will be in the after achievement of ROS up to the 20 minutes. And when a patient get ROS for more than 20 minutes, it is called sustained ROS. During this phase, we have to treat and evaluate the precipitating cause that have caused this arrest. This has to manage adequately, and we have to rule out the 5H and 5Q. What are the reversible cause of cardiac arrest? That has to be evaluated within this 20 minutes. Then during the early phase, that lasts from 20 minutes to 6 to 12 hours. During this phase, we have to we have to limit the ongoing injury to the organ that most commonly affect the brain and the cardiac. So in this phase, we have to optimize our hemodynamic function. Then in the recovery phase, which is persist start from 7 to hour, during this phase, we can neuroprognosticate the patient and we can tell about the survival of the patient if we can tell the attendant about the prognosis of the patient after 7 to hour. Then if the patient survive and get discharged, then we have to, if he has any disability, we have to get the rehabilitation after this phase. Then what is post-cardiac arrest brain injury? This is the most common cause of death in out-hospital cardiac arrest. Around 68% of the cause of out-hospital cardiac arrest, a patient who got lost, they got death because of this post-cardiac arrest brain injury. And the most vulnerable site of the brain are the hippocampus, corpus luteum, and the thalamus. It's mostly occurred due to the fixed dynamic microcirculatory failure that occurred due to the ongoing systemic ischemia and hyperfusion. And the impaired cerebral perfusion pressure and the autoregulation exacerbate the brain injury more and more, making it a vicious cycle. And regarding the post-cardiac arrest myocardial dysfunction, there occur a myocardial stoning. A myocardial stoning, it means there will be transient global dysfunction. There will be global hypokinesis of the heart, but the blood supply to the coronary blood flow it is maintained. And multiple studies has been trial, multiple preclinical and clinical has been done, which indicates this is a reversible cause. If we are treating the hemodynamic cause, if we are treating it, then it can be a response to therapy and it can be reversible. And the cardiac index which decreased during this time that can be improved substantially by 24 hours, and mostly it is improved within 72 hours in most of the studies. And what is the component of effective post cardiac arrest care? The first and foremost thing is we have to identify and treat the precipitant cause that cause the cardiac arrest. We have to rule out the 5P and 5T, and we have to do the investigation, relevant investigation with the suspected history to get the immediate cause of the cardiac arrest. Then we have to assess and mitigate the ischemic perfusion injury. This has to be managed because if we won't able to manage this, we will lose our patient. Then the 2020 ACLS guideline, they have provided algorithm for adult post cardiac arrest care algorithm. This is the algorithm. It starts with the initial stabilization phase and a continued management with additional emergent activities. When ROS positive, initially we have to manage the airway breathing and circulation. During our ED, we mostly do the horizontal resuscitation. If we can do the horizontal resuscitation, we can do all the things simultaneously. So we will stabilize the patient more early. If we will a single, then we have to do vertical resuscitation with which pathway which will kill the patient first. So we have to manage the airway first. In case of airway management, we have to pay. I will be discuss the topic subsequently in the later slide. In this phase, initially we have to manage the area by early placement of endotracheal tube. Then we have to manage the respiratory parameter with the goal what the ventilator setting, what will be the normal SpO2 and PSO2 level, and we have to also manage the hemodynamic parameter. And then we have to obtain a 12-day SCG within the initial stabilization phase. After that, we have to after getting the 12-day SCG, we have to consider what are the indications of emergent cardiac intervention. Where we have to shift the patient to cath lab immediately. Then after that, we have to see the response of the patient. If he is able to follow the commands or not. If he is able, then we have to next do the other critical care management. And if he is not obeying command, then we can try for any pathway that can improve the neurological recovery. 2020 AHA guideline, it recommends TTM targeted therapy management is one of the goal to improve the neurological recovery, and we can obtain a brain CT during that time. The brain CT has to be done within 24 hours after cardiac arrest. Then EEG monitoring has to be done. I will be providing all the topics subsequently. Then the post cardiac arrest care management. How will you manage the case? The normally how we manage the case, we follow the ABCD rule. Here also we follow the same ABCDEF rule. Here in the airway breathing, what are the we will study? We have to see what are the hemodynamic goals that we have to achieve in post-dose patient. What will be the ideal oxygen level? What will be the oxygen? What will be the ideal CO2 level? In the circulation part, we have to see what are the hemodynamic goals, what will be the ideal map, and what will be the ideal systolic blood pressure, and what are the indication of emergency coronary angiography, and is there any role of arrhythmia prevention during the post-arrest care. Then in the disability and exposure part, we have to see if we can take a patient for target temperature management of is there any role of seizure prevention. Then regarding the F and F part, for future prognostication, we should do clinical examination with imaging like CT and MRI. We can do electrophysiology and novel biomarkers. So for hemodynamic goals of air and breathing, for airway, we should ensure a patent airway. They should, as soon as the ROS been achieved, we should try to early placement of an endotracheal tube. And the 2020 AHA guideline recommend we should use the waveform capnography to confirm the endotracheal tube and for monitoring of the patient. This has to be done. Then after we securing the airway, we have to put the patient on a ventilator. So what will be the mechanical ventilation strategy we should follow in post ROS care? Study has been tried in 2020. It has been suggested we should follow the lung protective ventilation. So we should follow the long tidal volume strategy. It has seen by following the long tidal volume strategy, it has improved the neurological outcome. It has decreased the ICU stay, and it will decrease the presence of cardiac so in this patient during post-ROS state. And we should avoid hyperventilation. Why should we avoid hyperventilation? I have already discussed. And we have to start the ventilation at a rate of 10 per minute, and we have to adjust to achieve a target of PGCO2. So what is the target level of PSO2 in this case? As per the ILCA recommendation, they suggest to avoid hypocapnia because hypocapnia will cause cerebral vasoconstriction and it will decrease the cerebral perfusion. So it will worsen the outcome. Then many studies will try to find if there is any benefit of targeting a mild hypercapnia because mild hypercapnia it may cause cerebral vasodilation. It may increase outcome, but study have shown it has worsens the neurological outcome. So it also been avoided. So from the summary of the available evidence and as per the AHA guidelines, we should target normocarbia. The PSO2 should be maintained within 35 to 45, with the ETSO2 has to be maintained from 30 to 40 in this case. Then we have to titrate the tidal volume and the respirator according to that to achieve the target PSO2 of 35 to 45 from the initial setting. Then what are the hemodynamic goals or regarding the oxygen? Any patient who is present with posters, we initially will start with the highest stable FiO2. As we D in our ED, after intubation, we will start the patient with FiO2 of 100%. Then what is the target level of SpO2 that we have to maintain? As per 2020 AHA guidelines, the time till we don't get a value of SpO2 or PO2, that is the time we will not able to get a pulse oximetry, till we are able to monitor the SpO2, we should start the patient with the highest available FiO2. Once we get the PO2, or if we can manage the SpO2, we can monitor the SpO2 through a pulse oximetry, then we can down titrate the FiO2 to manage to attain a target level of SpO2. As per the 2020 AHA guidelines, it recommends a SpO2 level of 92 to 98%. This has to be maintained. And there are multiple studies have been going on if hyperpyrexia is beneficial or it is detrimental. Then a study recently published by Coma Care Study Care where it suggests that hyperoxia is not associated with any detrimental neurological effect during the post-host care. So we should attain a normoxia. Then regarding the hemodynamic goals in circulation, the heart is the important part. If the heart will not purpose, it will not the circulation will not improve and it will exacerbate the cardiac injury, also the brain injury. So we have to immediately correct the hypotension. Then what is the goal of mean arterial pressure and the systolic blood pressure? According to the 2020 AHA guidelines, the systolic blood pressure should target more than 90 millimeter of mercury and MAP should be maintained more than 65 millimeter of mercury. For this, what we can do as a general management? Initially, we can start with IV bolus. 1 to 2 liter of NS or RL can be given. You have to see the response of the patient. If the patient is not responsive to fluid, then we can start with inotrope. Initially, we can start with norepinephrine. The dose will be 0.1 to 0.5 microgram per kg per minute IV infusion. Here we will mostly perform this by taking 8 milligram of epinephrine in 50 ml of NS. Then we prepare a solution. So according to for a 60 kg person, it will be more like equivalent to 360 microgram per hour. So we have to titrate start the infusion at a rate of 2 to 3 ml per hour initially. Then we can titrate to maximum dose of 15 ml per hour. Then the dose of epinephrine will be 2 to 10 microgram per minute IV infusion. And in case of cardiac infarction, we can start dobutamine or dopamine. Dopamine dose will be 5 to 20 microgram per kg per minute IV infusion. Then there are multiple studies being given by the Coma Care study group. They focus on targeting the no normal or high normal mean arterial pressure after cardiac arrest. They wants to find if there is any benefit of getting a high normal mean arterial pressure for neurological outcome. They in this study they take the normal BP as a map of 65 to 75 millimeter mercury and high normal BP as a map of 80 to 100 millimeter mercury. And this in the primary outcome they want to see if the map has been assessed with any increase. They assess the map along with the marker of neurological injury. If the neurological injury markers are increasing or not. In this case, there is no significant difference in both the duty. Then, what are the indications of immediate coronary artery angiography? What are the indications? So, after post-dose, we should do an ECG. If the ECG showing ST elevation in the ECG, then it is the class 1 recommendation of 2020 AHA guidelines to shift the patient catheter immediately. Then, if we are finding we are suspecting the arrest may be due to cardiac origin, then but there is no ST elevation, then we have to see for the vitals. If the patient is either electrically unstable or hemodynamically unstable, if the patient either is in cardiac shock or the patient is having recurrent arrhythmia, then we can go for cath lab immediately. This is the class 2B recommendation of evidence. Then in other case, most of the guidelines are silent about this topic. Then A famous co-op trial has been published in 2019 about the study the coronary angiography after cardiac arrest without ST segment elevation. The trial was published in 2009 when the inclusion criteria they include the patient who is present with out hospital cardiac arrest and the initial rhythm was shockable and the patients are unconscious after the ROS and they exclude the criteria which are already we have taken for the indication of cath lab immediately and the STEMI, refractory arrhythmia and cardiogenic shock. Then this is a randomization study with multi-center study with the open label with 1:1 allocation. Then in the intervention, they do the coronary angiography within 2 hours of allocation of the patient, and in the control arm, they do the coronary angiography after favorable neurological outcome. Then in the primary outcome, they found that there is no significant difference in between the control arm and intervention arm. The primary outcome is survival in 90 days. There is no significant difference. Also, there is no significant difference in the secondary outcome. The secondary outcome are survival to ICU discharge, and there is also no difference in the side effect like recurrent arrhythmia and time to inotrope support. So, in this study, they found that acute unstable correlation are found in 99.9% of the cases of cohort, and death is more likely due to neurological cause rather than the cardiac cause. So this study most likely signifies that if a patient present with out hospital cardiac arrest with initial shock abdomen, but the ECG is showing not any ST changes, so there is initially no immediate requirement of coronary angiography for this case. And regarding the arrhythmia prevention, according to the in post-stress care, there is very less. There is according to the 2020 ASA guideline, there is very less evidence to support the if there is any indication of anti-arrhythmic during the post-stress care. And Ilkor also was silent about this topic. Then according to the summary, we can show that there is we shouldn't start arrhythmic in post-stress care, but we should able to correct the cause that may cause precipitate the arrhythmia. We should correct the electrolyte dysfunction. If there is hypokalemia or hyperkalemia, this has to be corrected. If there is an acute microinfarction that may cause complication due to different arrhythmia, this have to be sorted out. If there is a toxin, and regarding the disability and exposure, we have to focus on targeted temperature management. According to the 2020 ASA guidelines, this is the only measurement that can cause improve in neurological outcome. Then another is if there is an indication of prevention of seizure during the post-stress care. So regarding the target temperature management, we will discuss what is it and what are the inclusion and exclusion criteria of targeted temperature management and what are the phases of TTM with the regarding adverse effect. This is the process of cooling of a recession adult cardiac arrest patient to a core body temperature of 32 to 30 degrees Celsius following ROSC. How will act? By it mostly act as a neuroprotective agent and it has an anti-epileptic effect and it will improve the energy balance. How will it will act as a neuroprotective agent? It will decrease the CNS edema and it will decrease the inflammation due to the hypothermia. And in case of anti-epileptic effect, it will decrease the calcium influx. So it will decrease excessive neurotransmission. So you can prevent any arrhythmia during that phase, and it will decrease the oxygen consumption. This will leads to decreased mitochondrial dysfunction that leads to positive energy balance. And regarding the criteria when patient, we will suggest TTM. It's taken from Tintin. The inclusion criteria being if the ROS is negative and DCS with M score of less than 6, and there is no other reason, there is no only precipitating cause of coma, like there is no other cause of toxin, hypothermia, this we have to be ruled out. If these are present, then we should treat this cause rather than going for TTM. Then the age should be more than 17 years. And regarding the exclusion criteria, if the patient is awake or if the arrest is because of a traumatic etiology or any patient having severe bleeding from any part, and if the cerebral performance score is around 4 to 5 before cardiac arrest, the cerebral performance score it is a disability. It is a score to predict the disability in a patient after post cardiac arrest. This has been also been followed by the Woodstein guideline. And according to the CPP score, the CPP score on it mostly signifies patient have a good cerebral performance. CPP score 2, it signifies there is moderate cerebral performance. So then in case of CPP stage 3, there will be moderately severe, and in the CPP stage 4, the patient will be in comatose stage, and in case of CPP stage 5, the patient have a brain death. So if a patient having a CPP score of 4 or 5 after before the arrest, we shouldn't try for TTM. Then if any patient having a DNI or DNR shuttle, we shouldn't try for these are the exclusion criteria of TTM. Then and we see if patient is on anticoagulant therapy or if the patient having a long QT syndrome, these are not an exclusion criteria for TTM because While TTM we are giving hypothermia because hypothermia can precipitate this condition. Initially thought that this may be the contradiction, but adverse internally these are not the exclusive exclusion criteria for TTM. Then regarding the targeted temperature management, it starts with the cooling phase. In cooling phase, we have to find if there is any role of pre-hospital initiation of TTM. As per the 2020 guidelines, this shouldn't be followed. This is the class 3 recommendation, and the level of evidence was A. Then according to the when should and at what time we should start the TTM. According to the itinerary, it should be started as soon as possible and should be lower the body temperature within 4 to 6 hours after rest. Then about the cooling phase, we have to monitor the core body temperature. Mostly the constant will be the central venous temperature, but we mostly where we can use the esophageal probe, bladder temperature or the rectal temperature. But the most common and the most sensitive test will be the esophageal probe. It will be accurately measure the core body temperature. And what will be the rate of lowering the temperature? It should be lower in the cooling phase according to 1 to 2 degrees Celsius per hour. Then what are the methods we can use for cooling the patient? We can use intravascular cooling, where we can use IV infusion of 4 daily saline. The dose will be 30 milligram per 30 ml per kg. We should can give in 1 liter of cold NS that should be infused over 1 hour, and we should decrease the temperature by 1 degree Celsius. Then what are the methods? Other methods we can use? We can use ice packs, cooling blankets, and cooling vest. And the rate also we have to achieve a cooling method that should be we should be cool the patient at a degree of 0.5 to 1 degree Celsius per hour. Then the initial regarding the target temperature initially there are Hakka and Bernard trials. They have been proposed in 2002, but there are of less evidence. And in the Hakka trial, it suggests that there is an improvement of around 14% in the intervention group, but it was very less likely to happen. So these are and the evidence were very low from this stage. Then after that, from that time, that concept of TTM was started. After that, the TTM1 trial was come in 2013, where they manage the target temperature management at 30 degrees Celsius and 36 degrees Celsius after cardiac arrest. In this case, the primary outcome being the death at the end of the trial. In both the arms, we are not finding any significant difference. So whether is which one is good. And regarding the duration of TTM, so how long we should continue the TTM? According to the 2020 AHA guidelines, we should continue TTM for minimum 24 hours. Then many studies have been started, and Tiger et al. Conducted study so whether to start continue TTM for 24 hours or 48 hours. In this case, we can see in the graph there is no significant difference in the neurological outcome in either in between the control and intervention arm. So it not give any evidence of whether we should control the study for 48 hours or not. So as per 2020 AHA guideline, we should minimum continue the TTM for 24 hours at least. And regarding the maintenance, what we have to check for? Fever is a component that have a very poor neurological outcome and poor prognosis during the post-arrest phase. So fever has to be allowed, has to be avoided during this phase. You have to maintain the map of more than 60 millimeter of mercury because during this hypothermia there is a more chance of hypotension. This has to be prevented, and we have to check the electrolyte every 4 hours. Mostly we have to see the potassium level. There is a more chance of hypokalemia and hypothermia during the TTM. Then we have to monitor the severing using the bedside severing assessment scale. Because during the in the cooling phase, there is a more chance of severing to be happen. So this has to be avoided for a optimization of therapy. So we can assess and monitor this by using the scale, bedside severing assessment scale. And we have to use the anti-severing measure if severing is occur. So there is a Columbia anti-severing protocol which has been prescribed to assessing the bedside severing assessment scale with a score of 0, 1, 2, 3, 4. According to the score, we should maintain a score of 0 to 1 during our cooling phase. And during the in score 0, there will be no severing. We can found clinically or not on the ECG. There will be no ECG evidence of severing. And in case of score 1, we can get the evidence of severing from the ECG. In these cases, in this case, we have to start it from the baseline, from the stage 0. Any person who is starting with TTM, we should start from to give anti-severing measures. We can start with acetaminophen. The dose will be 1 gram QID in normal patient. If a patient is cirrhotic or having any liver disease, then we should decrease the dose to 650 milligram TDS to prevent toxicity. Then another one thing we can use bosphirin, and magnesium sulfate is used if the magnesium level is less than 2 milligram. Then if the score is 1, then we have to use the mild sedation like dexamethasone or opioid like ketamine have to be used. Why in this case the dexamethasone or ketamine are used? Because these agents they won't be affect the neurological outcome, and these are slow, these are rapidly acting. So their effect will be removed immediately. So we can get a better neuroproliferation during the neuroproliferation phase. If the score is 2, we have to give moderate sedation. We can continue both dextromethorphan plus opioid. Opioid we can start with propofol. The dose of propofol will be 50 to 70 microgram per kg per minute, and the dose of dextromethorphan will be 0.2 to 1.5 microgram per kg per minute. Then if the patient is the shivering is not improved after that, then we can start with propofol infusion. The infusion should be 50 to 75 microgram. And after that also, if the patient is not improving, then we have to our last resort will be neuromuscular rotation. We have to start with vicuronium. The dose will be mostly 0.1 milligram per kg. IV insulin that has to be given. But in this test, we have to try to achieve a score of 0 to 1 because after that, the agent which we are using, they can affect the neuroproliferation. And regarding the revival phase, this is the most in the rewarming thing, this is the most dangerous phase of TTM because due to the rapid rise of temperature, there will be increased vasodilation and that may leads to hypotension and raised ICD. So ideally, we have to raise the temperature gradually. It should be less than 0.5 degrees Celsius per hour. Then what are the potential adverse effects of TTM? It may cause bradycardia, it may cause prolongation of Q2 because of hypothermia, and it may cause coagulopathy. These are most the three side effects will occur due to hypothermia if you are taking the temperature around 32 degrees Celsius. Then hypokalemia and hyperkalemia both are occur. Hypokalemia mostly occur during the cooling phase. Then shivering can occur, and in very rare cases, there can be non-systemic ventricular tachycardia. This can be occur due to prolonged hypothermia. Then the next the famous trial TTM trial has come in 2021, which is a randomized clinical trial where that compare the target hypothermia versus target normothermia after out of hospital cardiac arrest. This study shows in this study this is an open label trial with a blind outcome. The assessment the person who are assessing the patients for neuroprotection they are being blinded in this case. Then in this case they taken with 815 patient comatose patient after out hospital cardiac arrest and the initial rhythm was shockable where they compare the effect of hypothermia and normothermia in this case and they take the primary outcome as death from any cause at 6 months. And in this study, we don't find any significant result in between the control arm and intervention arm. So this study mostly signifies that also in the secondary outcome, we can see that the arrhythmia due to hemodynamic component it is more common in case of hypothermia. So we can conclude from this study that the hypothermia can be less beneficial. It can causes more adverse effect. So what can we do in our body? So as per the 2021 TTM2 trial, so there is less evidence that targeted temperature management will improve the outcome in case of post-hospital. But this study also concludes that prevention of hyperpyrexia is beneficial for patient during post-RUSH period. So we can what we can do in our body, we can continually monitor the temperature by invasive continuous probe like esophageal probe that was trading in our body, and we should to prevent the hyperpyrexia. We have to monitor the temperature. As per in the TTM2 trial, they have targeted the temperature in normal as a 37.5 degrees Celsius. They have to optimize the temperature within that. If the temperature is increasing, they are giving the anti-severing measure and the antibiotic measure to control the temperature. That we can follow in our ready. And we should have a close monitoring of the temperature. I have taken this table from MTrip where they follow the TTM2 guideline and follow a multimodal control system for temperature and severing management. Now, what we can do for maintaining of temperature in post-stress phase. So, any post-stress patient who is unable to follow verbal commands, what we can do? We can see the temperature. Then initially you have to start the basic temperature package. We have to do, as per I say, we have to insert a continuous temperature management monitor. Either oximeter we can use and we can monitor the temperature. And we could start the scheduled antibiotic like we can use PCM as 1 gram QID or if patient has cirrhosis, then we can start at 65 milligram TDS. Then we have to monitor the temperature. If the temperature is less than 37 degree 8 degrees Celsius, then it is okay. We have to continuously closely monitor the temperature. If the temperature is increasing from more than 37.8 degrees Celsius, then we have to start the advanced temperature package and the tier 1 anti-severe drugs that I have already discussed in the Columbia anti-severe protocol. And we have to we can give give a dose of Bespirone 30 milligram per tube QID, or we can give magnesium sulfate if the level is more than up to attain a normal level of more than 2 milligram. Then after that also, if the severing is not maintained, then we have to try the tier 2 anti-severe therapy, where we can use dexamfetamine or propofol infusion, and we can try also for ketamine infusion, and the magnesium level has to be maintained again more than 2 milligram. Then if after that also the severing was not improved, we can follow the tier 3 anti-severing therapy, where we can start with the fentanyl bolus or paralysis that and if after that also the severing was not improved, we can go for neuroparalysis agent like vicodinum. But in this case, we should try to get maximum the type 1 anti-severing title, because if you are giving fentanyl or maybe paralysis like vicodinum, these are the long acting drugs, so it will be difficult for us to get the neuroprognostication in the next phase. They will affect the neuroprognostication. So we have to target to get the result to optimize the temperature at 37.8 degrees Celsius and to achieve a target of more less than that. Then, is there any role of seizure prevention in post-dose phase? According to the 2020 AHA guidelines, there is no indication for giving any prophylactic anti-epileptic. But what we can do an ECG, we can do EEG to monitor and diagnose if there is any seizure activity. Regarding that, we can give the anti-epileptic drugs. And what are the other post-excision care that we can give? According to the 2020 AHA guidelines, if we are able to do, we can elevate the head to 30 degrees Celsius if the patient is tolerating. But how can we, by doing that, we can prevent the cerebral edema, to decrease the chance of aspiration and decrease the chance of ventilator associated pneumonia. Then regarding the optimum glucose level, there are many studies being tried, but there is no optimization of glucose level that can improve the neurological outcome. So many studies are, you have to also get a glucose level that we have to follow in critical care setting. Mostly according to the 2020 AHA guidelines, we have to maintain a glucose level of 150 to 180 milligram per deciliter. As per our continually, the glucose has to be maintained from 100 to 180 milligram per deciliter. Then there is also in the study, they have found that there is no benefit of giving a prophylactic antibiotic during the post-arrest phase or giving any neuroprotective agent. Also, the routine use of steroid is not recommended in the post-arrest phase as per the 2020 AHA guidelines. Then regarding the prognostication, there are four modalities. We can do the prognostication by clinical investigation, clinical examination, by doing imaging by CT and MRI, by doing the electrophysiology and biomarkers. So the timing of outcome prediction for clinical examination, if a patient is on TTM, we have to do it after 7 hours after return of to normothermia. As the TTM, it takes around minimum 24 to 48 hours. So typically, neuroprognosis in case of TTM has to be done 4.5 to 5 days after the loss. Then in case of patient who is not on TTM, the neuroprognostication has to be done 72 hours after cardiac arrest. Why it mostly doing after 70 after cardiac arrest? Because for the neuroprognosis, the tools which are using, we should use the tool which have a very good specificity and having less false positive rate. And recent many studies have been given that those we are using these tools have the least false positive rate at after 7 to hours. So we are following the guideline of to get the neuroprognosis after 7 to hours. Regarding the clinical examination, if we are getting an absent bilateral pupillary reflex after 7 to hours, then it is a false positive of around 0%, but it may be 0 to 3%. And if we are finding absent bilateral corneal reflex, it also has a very bad neurological outcome. Also, if you are finding any extensor posturing or there will be no motor response to pain like M1 or M2, then it has also very poor prognosis. But it has a relatively high false positive rate. Then, if you are finding any myoclonus within 7 to hours of cardiac arrest, then it is a very bad poor neurological outcome. And if you are finding status myoclonus, that is, if you are finding repetitive myoclonic activity that is persisting for more than 30 minutes, then it is called status myoclonus. If you are getting status myoclonus within 24 hours, that is also provide a very bad prognosis. And regarding the electroencephalogram findings, In comatose patient post ROS who are on TTM, if we are finding persistent absence of easy activity to external also external stimuli at 72 hours after cardiac, it provides a very bad neurological outcome. And we are finding persistent burst suppression and ESG or repetitive activity, then it is also a favorable, it is also poor neurological outcome. In comatose patient post ROS who are not on TTM, if we are finding persistent burst suppression on ESG after 72 hours of cardiac arrest, it also had a very poor energy outcome with a false positive rate of around 0%. And about the somatosensory evoked potential, we can, if we are finding bilateral absence of somatosensory evoked potential where between 24 to 72 hours after cardiac arrest or after rewarming, it has also very poor neurological outcome. Then it is very difficult to do this somatosensory evoked potential. Then about the electroencephalography findings. Regarding the CT imaging, in the regarding the imaging, in we can do CT. CT mostly in post cardiac arrest, CT has to be done within 24 hours. In case of post cardiac arrest patient, it will we will found mostly the brain edema, and normally the gray white ratio is around 1:3, but during the edema this ratio will be decreased. If we are finding in post edema, the edema will decrease the gray white matter ratio. Then regarding the MRI, we can do the diffusion weighted imaging where we can found the apparent diffusion coefficient which the norm which will be decreases in case of post cardiac arrest due to edema. Then regarding the blood markers, we can use neuron specific analysis in S100V. Many studies have been given, but not in single one studies have specified what will be the ideal level of these markers to get an poor neurological outcome. And these two markers have a very high false positivity. So these two markers alone can identify the poor prognosis of the patient. This is the 2012 recommendation suggest. Even the possibility of high false positivity and the blood level NSA that hasn't been titrated to what is the ideal blood level for prognosticating a bad prognosis, these markers should not be used to predict the neurological outcome. This is a class 3 evidence. Then, according to the summary, the neuroprojection has to be done after 72 hours. So it is very difficult to do in our ready to get a neuroprojection. Then regarding the ethical issue in dissertation, I will be covering the heading with what is the advanced directive. Now, what do you mean by fertility? Now, what are the criteria for not starting CPR? Now, what are the criteria for terminating the resuscitative effort? Now, what is the duration of the resuscitative effort? And the indication of family presence during resuscitation. Regarding the fertility, a intervention is mostly called futile when there is absolute impossibility of success outcome. When we are getting, there is a very low likelihood of getting a loss, a very low likelihood of survival to hospital discharge, or a very low likelihood of the restoration of meaningful quality of life. So, and as the education, it is also very difficult to determine which is if a patient is fertile or not. So, we have to get the decision of whether the patient is fertile or whether we have to not giving to whether we not have to give the CPR will be discussed by based upon our well accepted research result, and we have to collaborate this along with the opinion of the patient and family, and we have to give a professional judgment regarding that. And regarding the advance directive, advance directive it means if any expression of a person thought or wish or preference for his end life care, if he was in his advance directive, if he was willing to not be resuscitated during the last day, we can consider it. It mostly a type of it is a type. It can be a conversation, or it may be a written directive, or it can be a living will. Mostly in US, these guidelines are this is routinely followed, but also in the US, as per the 2008 guidelines, an advance directive cannot be used to withhold life-sustaining treatment unless these conditions are met. Before withholding any life-sustaining treatment during cardiac arrest, if a patient have a advance directive, we should have to prioritize these things. There should be a surrogate who is given authorization for withholding the life-sustaining treatment. Then the patient has the terminal condition. It should be certified by two physicians, either by two physicians or the patient is in a persistent vegetative state. That should be certified by two physicians, including one who is a special expert in evaluating the cognitive function. This have to be made. If these are made, then we can think of withholding life support in a case. Then what are the criteria for not starting CPR? If a patient getting a valid DNR order and if we are finding of sign of irreversible death, like if we are finding rigor mortis, if there is decapitation or there is dependent lividity, then we can we can we shouldn't try for CPR. Then if we are finding any no physiological benefit that can be expected because of the vital function that has been evaluated and despite the maximum therapy, such as condition like progressive septic or cardiac stroke, which is not respond to therapy. In this case, we can also plan for not starting the CPR. We can witness the patient. Then withholding attempt to resuscitate a delivery room in appropriate newborn if the newborn baby is less than 23 week gestation or his weight is less than 400 gram or if he is having evidence of anencephaly in a trisomy 13 or 18, then we can get a criteria for not starting the CPR. Then how will you terminate the resuscitation effort? This is a very long discussion and this is mostly depend upon the physician and the multiple factor like the time from collapse to starting of CPR because time is the most sensitive part that define the resuscitation. Because the more time it will elapse, that there is will be the less likely chance of getting the ROS, and if you getting a ROS, there is a less like chance to getting to probable to hospital discharge. So time from collapse to CPR that is an important factor. Then time from collapse to fast defibrillator because as soon as we as early we will defibrillate, there is a more chance of outcome of ROS. Then if there is a more you can assess the comorbidity of the patient and the pre-arrest phase and if the initial arresting. If the initial arresting is soluble, there is a more chance of getting a ROS. Then if we have to see the response to the restorative measures. If we are getting a high quality restorative measures, after that also the patient was not responding after 30 minutes of CPR, then we can plan for terminating the restorative effort. And if we are using 80 to probe, when we can see the 80 level is less than 10 after 20 minutes of high quality CPR, then there is a very less likely of we are getting a ROS after the best possible resuscitation. So if we have to not a single point we can use for terminating the CPR, we have to take all the points. Then you have to find, we have to decide whether to which is the appropriate time to terminate the resuscitative effort. But in these cases, if the any patient having pre-arrest hypothermia, if there is any history of drug overdose or any young overdose, we can we can try for prolonged duration of CPR in this case. So what will be my take home is after post cardiac arrest care, we should optimize the hemodynamic parameter as soon as possible. We should maintain the normoxia, normocapnia, and euglycemia, and we should activate a cath lab immediately if indicated if there is we are getting the indication that I have discussed before, if you are getting in STEMI or if you are getting a patient with suspected cardiac origin with NSTEMI having either electrical or hemodynamically instable, then we have to maintain regarding the TTM. So we should maintenance of normal thormia will be better during the post ROS phase rather than getting TTM. So and also the last but not the least, the neuroprognostication should be done after 72 hours. So if you do little clinical examination, then you have to imagine mobility and do simple. Sir, we have to do clinical examination. If we are finding bilateral absence of pupillary light reflex after 70 hours, there is a very poor neurological outcome. If we are finding bilateral absence of light corneal reflex, there is a very poor prognosis. If we are getting an extensor posture or are getting no response, no motor response to active, pain, then there is also poor neurological posture. If you are getting a then these are all clinical examination. Then on the electrocardiography, if you are getting in status myoclonus within 24 hours, that provide a poor prognosis. If you are getting myoclonus with after 70 hours, that is also provide a poor prognosis. Then in case of electroencephalopathy, we are getting burst compression suppression complex after 70 hours. That is also that's comprised with very poor outcome, neurological outcome. If if the initial rhythm will be
What about the poor prognosis? I am asking about the good prognosis. Neuroprognostication. You can have two prognosis, good or bad. Stuck. Let him answer now. You are not. That is is giving clue already. Tell. Are final year. You are also final year, na? Golak. अच्छा चलो Ertiga चल लो mic use करो ना okay presence of what your voice is like a mic बोलो
The presence of pupillary or corneal reflex done 72 hours after the achievement of loss, or absence of myoclonus until 72 hours. Then on EEG, absence of burst suppression pattern, and also clinically, if there is motor response to pain, and on EEG, also if there is a response to external stimulus. Then on imaging, which is done within 24 hours, there's absence of significant brain edema, and as he told, there is better outcomes on diffusion weighted MRI and better ADC scores.
so you see I flipped the question you got flipped Golak you should respond understand as a presenter you are asked the question okay take a breath I know you got stuck by my question right so take a breath logically think and then answer okay to him no
You have said that in coma case study group, there were two arms they have compared. One is low map, 65 to 70. The other one is 80 to 100 high map. So you said that there was no significant neurological injury, which was the primary outcome. But was there any complication which arrived by targeting higher map? Like, although we say that more than 65, we have to target map, but was there?
Secondary outcome, there is no increasing complication in the intervention also.
What were the secondary outcomes you have any idea?
There are discharge to ICU, survival to ICU, the admission, and survival to discharge. These are the outcomes. It's very discovery arrhythmia.
And the second question that I wanted to ask that internally they mentioned about bispectral index monitoring as the most specific imaging modality for. So what is that? Like I do not understand.
I will see and
Okay.
Special index is something you are guessing for the have correct, I'm not very sure. Guessing for the under part, recording easy. What is just go back and check. This is a very in the future education, especially say major OT procedure, including ECG procedure, major OT procedure, sometimes we are using. But बहुत ज़्यादा benefit तो उसका नहीं है. UT setting की क्या है आपके? Setting bispectral.
In advanced directive part, is it applicable only like there were three things that you told that you have to not give life-saving procedures only either of those three are present in the patient along with this advanced directive. So I wanted to ask, I had a doubt that what is surrogate authorization? Any relative?
yeah, any relative which then we can go for which holding the life system theory. Then we can go for that.
Even if the patient himself has written it before that he does not
No,
want.
because as per the 2020 study, if a patient has known the advanced directive, 2 months back, then after 2 months, he also there are a lot of study that has been conducted. And also in case of metastatic cancer, also there has been significant improvement to survival to hospital discharge, and so the patient's will of getting a life also improved. So there these advanced directives should be periodically monitored in 2 to 3 months. So this have to be conducted. So after if the patient has been arrested, we won't able to know his what is his wish. So we better to get a surrogate wish if you want to terminate the last support on. should be followed periodically.
Feedback to you. Show one of your previous slides. Yeah. What is the problem with this slide?
It's more crowded.
You know about it.
So the criteria is so
So understood, but still criteria, but